Hello, everyone. I am Haley Blackburn. I'm a clinical pharmacist and an assistant professor at the University of Montana, and have a kind of a background in doing education in interprofessional settings for climate and health education around our region.
Okay. So thanks for the introductions. Just going to go through a little bit of an agenda and talk about our learning objectives for the day before we jump into things. So this is meant to be an interactive session. So we've got a good number, 25 folks, but I think it should make for good conversation, and folks should feel free to speak up with questions or ideas that they have. We're going to be going through sort of a patient scenario. So I'll be role playing a patient, and Dr. Sbiroli will be interviewing me, and we'll be getting input from Dr. Blackburn and kind of talking through that scenario and engaging you all too. And then talking about what sorts of responsibilities come up based on that patient scenario, and kind of more broadly in terms of the various members of the healthcare team, from physicians, pharmacists, nurses, social workers, and anything else. And so that's kind of the plan for today. You can see the learning objectives up on the screen here. So our case is going to be talking about heat stress and the impacts on physiology. We're going to be thinking and talking about early heat warning systems and other measures to prevent negative health outcomes from heat exposure. We'll be talking about things specific to medications as it relates to climate exposure, specifically heat, and handling of those medications. And then, like I said, we'll be talking about the roles and responsibilities of different members of the care team. And I'm just quick checking into the chat here. So we are recording. Thanks for mentioning that, and sorry that I didn't say that out front. We can definitely, I think, send our slides along to the team, and I don't know exactly what their intentions are to do with the recordings, but my guess is it will be to publish them and share them with folks who signed up, or publish them on the website. So, and then for Lori, no problem. And for everybody, just participate in whatever way feels comfortable for you. If you just want to listen more, that's okay too. We're not planning to do small breakout rooms or anything like that. You're kind of expected to speak up. So yeah, with that, any other kind of initial questions or comments before we kind of get into things? Okay, and then for the classes, they said they would be sending info weekly through email. Yeah, that sounds like a likely scenario. And sorry, I don't have more of that background information. Maybe Emily, do you have a little bit more on that? Yeah. All right, so moving on. We're going to get into the case. I'm going to stop sharing my screen here, and we're going to do just looking at the gallery here.
All right. So I'm just curious, for those of you who are participating right now, can you just share either by tuning in or putting in the chat? I'm just curious what your training is. So if you're a medical student or a nursing student, or already practicing, if you could just share that, just so we have a little bit of a better sense of who our audience is today, and how to kind of guide this. So we wanted to share this patient case with you, and this case is really interesting. It's a really common case that we see in the emergency department, particularly where I work. So I wanted to be a little bit selfish and share with you my world. So if anyone is comfortable, we'd like to do this in a standardized patient type interview. So if anyone wants to take a stab at starting an interview, we'd like to collect information from our patient about his medical history, what brings him in today, the physical exam. Does anyone want to jump in and ask some questions to our patient? Otherwise, I can definitely do it. So, Mr. Patient, what brings you in today?
I'm just kind of groggy. my neighbors, I just woke up and my neighbors were shaking me and I felt really bad and they said they'd called the ambulance. And so I went with them. I don't feel too good.
Oh no, I'm so sorry to hear that. Juan is asking, when did it happen?
It's just today I started feeling funny. It's been so hot. Yeah, and I must have passed out.
Okay. Were you drinking any fluids? Asked Raluca.
I was trying to, but it's hard. I'm just sweating, just constantly sweating.
Did you injure yourself when you passed out?
No, I don't think so. Nothing really hurts.
Okay. Do you have any medical problems?
Yeah, I've got the diabetes. I got to do shots for that, and I have high blood pressure, and I got high cholesterol.
Okay. Do you know the names of any of your medications?
I take a blood pressure medication that's got the water pill in it, and then another, it's a combo pill. And then I've got, I take a pill for my diabetes twice a day. And then I have the insulin shots, and I have medication to help me sleep at night. And I've got another medication for my neuropathy, gabapentin.
Okay.
Yep.
And Lori is wondering, do you take your medicines pretty regularly, and did you take them today?
Yeah, I took my morning medications today. Yep. And I usually am pretty good about taking them.
Okay. And how long have you been a patient with DBT?
With DBT, sorry.
Yeah.
Oh.
Maria, do you want to clarify?
Oh, yeah. Oh, yeah. How long have I had diabetes? Yeah, about 10 years, I think it's been. Hasn't really been going very well. I feel like I have a hard time eating well. But I did have a couple of donuts this morning, Yvonne.
Is that all you had?
Yeah, that's all, and some coffee.
Okay, sounds good. Let's move on to the physical exam. So does anyone want to know anything specific about this patient on physical exam? How's your skin turgor? Now you can pretend like you're having an out-of-body experience and you're sharing your physical exam.
Okay. It's maybe a little dry. Yeah, I'm a little dry. I'm sweaty, but I've got dry mucous membranes. There's a little bit. I've got younger skin, so it's not really tempting or anything.
Okay. And folks want to know your vital signs.
Yeah, definitely. My heart rate is 132 beats a minute. My blood pressure is 85/54. I'm breathing 32 times a minute, and my oxygen saturation is 97%. I'm not using any oxygen though. And the EMS did a blood glucose on me, and it was 250.
Okay. Do you have any shortness of breath?
No, I'm not super short of breath.
Any palpitations or headaches?
No palpitations or headaches. It's just really sweaty and I'm just a little confused.
Okay. Do you have any trauma on you at all?
Let's see. No, I don't think so. No.
Okay. And how's your chest exam?
Yeah, so like I said, I'm breathing fast, but my lungs sound clear. And then in terms of my heart exam, like I said, I've got, I'm tachycardic, and then my rhythm is irregular, but no murmurs.
Okay. How about abdomen?
Yep, so it's soft and I don't have any abdominal pain, and bowel sounds are a little hypoactive.
All right. And what about neuro exam? I know you said you're confused. What does that mean?
Yeah, so I know where I am, I know who I am, but I don't know what time it is. All my cranial nerves are intact. It's funny to say that. And I can understand you and I can follow commands, and I'm able to move all my extremities, but I just feel a little kind of globally weak.
Okay. And let's see, Raluca's asking, would you say that your pulse is rapid and weak, or is it rapid and strong?
Let's say rapid and weak.
Okay, I would agree with that. And how about any nausea or vomiting?
No nausea or vomiting.
Okay. Anyone else want to add anything before we get to the summary slide? Any other questions for this patient?
All right, let me. Oh yeah,
Allergies.
Yep, I took penicillin one time and I got a rash.
Okay.
And no labs except for that point of care glucose at 250. Yeah, and I was just on the steps outside my apartment. Okay. And I was not exercising. No, just walking up the steps to my apartment. I live on the top floor. Okay.
Oh, it looks like it's the presenter view.
How's that?
Yeah. There you go. So I love it that Raluca and Maria are asking some pointed questions that seems to have conveniently been forgotten by myself and the patient. But where exactly was this? Where was this patient? And what was the temperature outside? And in fact, if anyone recalls, over this past summer, there was a heat wave in the Pacific Northwest. And this patient happens to be in it. So we took a trip back down back in time, basically. And so yes, he was in June in the Pacific Northwest, we'll say Seattle, and that's where he was. And so good job, guys, for narrowing it down. So I think Aaron, I think it's still not showing the full screen for the summary, just so that everyone can see it.
Okay, you're not seeing the whole summary.
No, we're still seeing the yeah.
Okay.
But I can review it. So basically we have a 45-year-old male in the Pacific Northwest during a heat wave, brought in by medics, who's a little bit confused. He was found very sweaty and found outside of his apartment. His past medical history, we determined that he's got diabetes, he's got hypertension and hyperlipidemia, and he did take, he is compliant with his medicines. Social history, he's a 1 pack per day smoker and he lives alone on the top story of his building. For allergies, he has a penicillin allergy and he gets a rash. And for his medications, the combination pill that he was talking about was Sbiroli. I don't know if I pronounced that correctly, which is a combo of lisinopril and hydrochlorothiazide. He's on metformin, Lantus, metoprolol, gabapentin, and Seroquel. And here's his physical exam findings. So we see his vital signs. He's pretty tachycardic. It's a little bit hypotensive when he came in, pretty tachypnic as well, with a respiratory rate of 33, but he's satting 97% on room air, which is pretty reassuring. And his blood glucose was 250. So this guy's pretty sick. is what I would say. Sorry, guys. And my dog is very upset about that. So I think we can, if everyone had a look at that, we can move on to, we'll talk about the pathophysiology of heat stress. So that's exactly what's going on with this patient right now. You guys nailed it on the head. This is for sure a heat exhaustion episode. And had he had a more abnormal neurological exam, he would have had a heat stroke episode, is what we would have called it. So I wanted to chat with you all a little bit about the pathophysiology of heat stress. And as we start experiencing more extreme events, we're going to start seeing more of these cases show up in our clinics, in our hospitals, even in our communities. And we need to understand what the underlying physiology of it is. We don't have to get too deep into this. This is from a medical textbook, but essentially what happens in the body when we experience high extreme temperatures of heat, you start activating different inflammatory pathways. You start getting cutaneous vasodilation in order to help the body cool down. So your body is going to be very focused on trying to cool down. So you're going to have cold seeking type behaviors. You're just from a mental perspective, the patient is going to start having cold seeking type behaviors. The skin is going to try to vasodilate so they can evaporate all of the extra moisture that's there to capitalize on the evaporative cooling. And then it's going to have an impact on our cardiovascular system significantly. We're going to start seeing high cardiac output and decreased venous return as we start having non-sensible losses from heat stress, which is going to then in turn lead to redistribution syndrome, where we start seeing changes in skin turgor, we start seeing changes in capillary refill. As we lose these insensible losses, we'll start seeing hypovolemia, and which will leave us into a state of shock. So all of these are all sequelae of heat stress, essentially. And on the right side of the screen, you can see the different kinds of diseases that end up that we can see manifesting in the body. So we start seeing things like heat syncope, where people actually vasovagal and collapse. We start seeing heat cramps, where lactic acid is building up in the muscles, and we start having musculoskeletal pain. We start getting heat exhaustion, which is what this patient essentially has. And then we start seeing decompensation and then stroke and things and signs of end organ damage. So I'm gonna turn it, we can actually move on to the next slide. So in terms of this actual patient and what happens with him, we need to remember that he was actually brought in by EMS. And so the care team for this patient is going to be very widespread. We're going to have a lot of hands on deck. This patient is among the sickest patients that we'll see. The EMS team, they're the first folks to see him. So they'll be the ones in the field. This is the ambulance that shows up at their house. We'll have a paramedic there. They'll be checking the vital signs. They'll be basically taking care of anything that's imminently life-threatening for this patient. And then they'll be making sure that he's stable enough to be transferred to the emergency department, where in the emergency department, we'll have an all hands on deck team there as well. We'll have our nurses, our emergency medicine techs, we'll have a respiratory therapist, a pharmacist, a physician, and then of course a social worker that's going to help with this patient. So the care team is extremely involved. And among these, I represent the physician aspect. We have Dr. Blackburn here, who's going to talk about the pharmacy aspect of it. And then the social worker is really important as well. Can anyone think of any reasons why the social worker is also part of this patient's care team right when he comes in? Yeah, exactly. So Yvonne mentions resource needs, and exactly need to know any environmental support, any environmental factors and the patient support network. That's exactly right. So what happens when we take care of this patient, we have to understand what were actually the circumstances that brought this patient here. What were the socioeconomic reasons and his demographics on why he may have been there? How is he going to be able to take care of himself afterwards? And how the hospital system can best support him. So these are the critical parts of the care team, and we can definitely expand on these later as we go into the discussion. But the disposition of this patient is really important. So can anyone guess, is this patient somebody who's going to go home from the emergency room after we stabilize him, or is this somebody that's probably going to stay in the hospital? Yeah, so Lori's thinking that he's probably going to stay. Yeah, exactly. Definitely stay depending on progression. And a lot of that is going to have to do with actually his social disposition as well. So most likely this patient will be staying in the hospital from the emergency room. It's unlikely that we'll be able to stabilize this patient. And if the heat wave is still going on, we can't send him back out into the heat wave back into his home where he had difficulty even caring for himself in the first place. So this is definitely somebody who will be requiring a lot of extra attention as well. So Erin, you can go to the next slide. And so I'm going to hand it over to Haley.
Thanks. So obviously, as a pharmacist, first thing we are looking at is, the medication list and thinking about which medications on this patient's list might be increasing his risk of some sort of heat-related illness and the risks associated with extreme heat. So we went through all of the pathophysiology there, and really there are a handful of different mechanisms that medications can work through to increase the risk of heat intolerance. So altering the central thermoregulation, impairing sweating, changing the ability of the body to peripherally vasodilate, causing sedation or cognitive impairment that might impair their ability to recognize that they're experiencing symptoms or impair that cold-seeking behavior. There's also potential for dehydration and hypovolemia or changes in cardiac output from certain medications. And then we also think about what is heat doing to the body that might change the way that the body is absorbing, distributing, metabolizing, or excreting the drugs. And so in extreme heat situations, you might see things where you'll have altered absorption across the skin through the transdermal route or through subcutaneous administration, where you have changes in perfusion at that site of administration in the case of maybe a fentanyl patch or subcutaneous injections, where you're seeing changes in the absorption rate. You might also see changes on topical administration with patients who are sweating. So difficulty there, whether it's patches or subcutaneous injections or topical creams, whatever. And then finally, changes in distribution and clearance of medications in patients that might be dehydrated and, as a consequence, have reduced renal clearance of medications. But one that we might think of there would be lithium. There are lots of others that would fall under that category. So just kind of broad overview of some of the first things that a pharmacist might be thinking about in this patient. If you want to go to the next slide. So looking at this and looking at the medications, I don't know if anybody, when they look at this med list, if there's anything specific that jumps out to them, and put it out there to the group. Or if there are any medications on this list based on the information that I just put out there and this in front of you that you would be concerned about.
Hydrochlorothiazide.
Okay. Let's see, metoprolol, lisinopril. Okay. Lantus. Diuretics, Seroquel. So he's got a lot on there, right? Almost all of them we're a little bit concerned about. So in the instance of diuretics, the people who offered up hydrochlorothiazide as a potential issue, can anybody explain why that is that would be a problem?
I thought hydrochlorothiazide because of the diuretics, the dehydration aspect, like being outside, you're going to sweat a lot, lose water. Hydrochlorothiazide is causing you to lose more water. So
yeah, yep, yeah, exactly. How about so somebody here has Seroquel. Tori put Seroquel in. So what category does Seroquel fall under, and why would that be potentially problematic for this patient?
Body temperature regulation, because antipsychotic.
Yeah, exactly. Yeah, so it falls under broadly the antipsychotic category of medications. A lot of times when we think about medications that broadly, if we're running through a checklist in our heads of meds we might be worried about, psychotropic meds in general, whether it's antidepressants, antipsychotics, sedatives, all kind of to varying degrees will increase the risk of heat-related illness. So yeah, the Seroquel as an antipsychotic, potentially changing thermoregulation. Also, it could cause some sedation that might potentially change his behaviors and his, awareness of symptoms and his ability to seek out cooler temperatures. Lori, you mentioned Lantus. So does anybody have any thoughts on what the issues around Lantus might be? So yeah, so Lantus is it's a longer acting insulin, right? We think of it as like a 20 to 24-hour duration of action with Lantus. And it is administered subcutaneously. So there is potential in this patient that he could have changes in the way that he's absorbing his Lantus if he does have that peripheral vasodilation. That subcutaneous medication could be absorbing more rapidly. That could be causing issues that would really lead to hypoglycemia. Can anyone think of any other issues potentially related to the Lantus in heat? Yeah, so Tori said, yeah, doesn't it need to be kept cool, and it expires? Yeah, and so that's definitely a medication that we're worried about product stability when we get to more extreme temperatures. And we can talk about that on the next slide here. So medication storage is kind of a third thing that we are thinking about as we're potentially looking at a medication list and we're thinking about issues that the patient is prone to experiencing. So in a patient with diabetes, insulin, the package insert says that the max storage temperature is 86 degrees Fahrenheit. And that's kind of in line with a lot of what we see for just standard room temperature is the max that we want to store any given medication. But there has been recent research out there and data that show no significant impacts on stability of insulin when it's stored. A couple of different conditions that they studied. One, when it was stored at 37 degrees Celsius or 98 Fahrenheit, or in cycling temps of between 25 Celsius to 37 or 77 to 98 Fahrenheit for up to 28 days, that actually stayed in range and that was okay. So it might not be that we need to be as strict as we've traditionally thought about for stability of insulin, but that's at 98.6 degrees. Think about somebody who's maybe storing their insulin inadvertently in direct sunlight on some metal surface or, in their car, they forget about it. There are a lot of places in an extreme heat scenario where temperatures are going to easily exceed that 98 degrees Fahrenheit and potentially break down the medication and make it less effective. So you could worry about actually the insulin no longer being effective and him being at a higher risk of hyperglycemia as a result. Other medications that weren't necessarily on his list here, but are associated with patients with diabetes, glucagon as Our emergency medication in the case of hypoglycemia is also a medication that is sensitive to heat exposure and is something that would be really unfortunate if it got exposed to heat and then it turned out that this patient needed the glucagon in an emergent situation and we didn't have working glucagon anymore. And likewise, the newer injectable GLP-1 receptor agonists are also more sensitive to temperature extremes. Other things, just thinking about like storage and equipment and everything that the patient might be managing if they have diabetes in an extreme heat scenario. So sweating with people who have either insulin pumps or continuous glucose monitors, that can cause issues with those not wanting to stick to the skin, potential dislodging of the devices. Another thing, accuracy of meters and test strips in extreme temperatures is all over the place. So that's a patient education point to make sure that they're not storing these things in places that are going to get really hot in the same way that they would store their medications. And likewise, that if they get some really weird reading that's totally out of range, to think about what temperature their device has been. And then the final thing to know about or to think about with this patient, just as another little pearl. So he's taking gabapentin, maybe has that peripheral neuropathy, and might be, is he out thinking about walking on a sidewalk in bare feet during an extreme heat event or something like that, where we're worried about him actually sustaining burns from that. So just general considerations in this patient with diabetes, and for stability in extreme heat for a lot of different medications. Some general rules to think about in the same way, kind of the tip of psychotropic medications, blood pressure, diuretics are ones that we maybe want to flag and think about for heat being an issue. For medication stability, medications that are made out of proteins are ones that are typically more susceptible to heat. So when we're thinking about the insulin, the glucagon, hormonal contraceptives or different hormones, biologics as medications, antibiotics, and then the emergency medications like an EpiPen or naloxone that would be needed in, maybe patients have them with them for a longer period of time, but then they're really highly needed in an emergency situation. Those would be ones that we would want to make sure that patients are storing appropriately and that it's not getting exposed to extreme heat. This slide I just had in here as something kind of thinking from a team-based perspective. So this guy, he was living alone on the top floor of an apartment. We know he has chronic conditions. He has a lot of medications. He's socially isolated. And so any member of the care team, even without getting deeply into his medication history or any of his other medical things, can probably recognize some of these factors and flag him as somebody who could be at high risk of having issues in extreme heat. So if I was a pharmacist out in a community pharmacy setting, and I saw this guy come in every month to pick up his medications, I knew a little bit about him, I could be the one to take the proactive step to say, hey, it's going to be really hot this next week. Did you know that, here are these resources as a patient you can use to prepare for the heat, or here are the things you need to be aware of with your medications or whatever. Likewise, if you're a social worker, if you're a nurse, whatever it is, it's sometimes just these broad characteristics, I think can potentially be the things that you can recognize up front and maybe take some proactive steps.
Oh, awesome. Thank you both for sharing and presenting a lot of good information. I know that was a surprise to me to think about insulin being stable at slightly higher temps, but then like you were saying, always having to remember like, oh yeah, the spot right next to my windowsill or whatever might actually be 120 degrees or more or something like that. So that was super interesting. So we are going to move into more of a general discussion here. I'm going to stop sharing my screen so that we can see faces. And I guess I'd like to first just open it up and see if folks who are attending have questions that you want to put out there. And it could be questions for either of our presenters. It could be questions just for the group in general. So kind of based on this case and thinking about heat and heat exposure. So I'll pause for a moment and see if folks have things they want to share.
I have a question about the difference between being photosensitive and being heat intolerant to medications. So could the same medication that causes the heat intolerance also cause like photosensitivity issues and give you like make you more prone to sunburns? Or are those kind of more two separate type of issues?
That's a really good question. I actually am glad you asked that, because I meant to mention that as an aside. Is, you know, extreme heat often comes with extreme sun as well. And so thinking about risks of medications with photosensitivity is always a good idea in these sorts of scenarios as well. So it's not necessarily the same exact mechanism, but, you know, we do think about like diuretics causing potential increased risk of heat-related illness, as well as potential risk of photosensitivity. But like in the case of, you know, our tetracyclines or something, some antibiotic that causes photosensitivity, that's kind of a separate issue. So there is some overlap there for sure. And keeping that in mind is important. But yeah, they are kind of not one and the same always.
I'm just curious, I see in the chat, and it's actually really cool that Raluca, that you're here. Do you want to maybe share a little bit about your experience with the heat dome, if you were there during the heat dome, or what your take on that was?
Yeah, so unfortunately I don't practice clinically because I teach in the university, so I do interact with the nursing students, but I am very involved with climate change content. And so the thing here in BC, though, I remember when the heat dome was for, I think we had it for around 3 days when the temperatures were really high, when it also coincided with that wildfire in Lytton that essentially eradicated an entire town. But what I've actually learned from my colleagues in the field is that the interesting pieces around the emergency preparedness aspect and the response rate of paramedics not being able to keep up with the calls, which is what actually probably was one of the key factors that contributed to people not getting the help they needed, because there is just such a scarce amount of people available to respond to these calls. And so initially, I know the media had portrayed the mortality rate was around 400 to 500. But I actually have a connection with the key researcher here in BC. If you want to look her up, she actually does a lot of her work on social isolation and heat-related events in addition to climate change. Her name is Dr. Sarah Henderson. And so she did find that we really should be looking at individuals who experience marginalization and are the ones who are living in isolation. And yeah, another thing I've learned from a webinar of hers was that majority of people who have passed away were actually in areas that, I mean, this is no surprise to us, but in areas where there's less green spaces. And so most of the deaths took place in like no areas where there are parks or trees or whatnot. So as an individual during the heat dome, I feel very privileged that I had access to AC, but I can't imagine, it was just, you could not go outside. It was just impossible. Like you would go outside and it would feel like it was an oven. And I can't imagine how our population on the downtown east side was facing this, because you had the pandemic and you're told to isolate or stay away from people, but then you're also kind of encouraged to go to cooling centers. And so there's this like, well, what am I supposed to do? Do I go there and stay near people because it's cool, but then I could expose myself to COVID? Or so it's a very complex issue, and I'm just hopeful that we learn from this so that we actually can prepare for for the next heat dome, which we should stop saying that, oh, it happens once in a while. I hate it when the media does that. So yeah, those are my thoughts.
Looks like Juan has his hand up. Go ahead, Juan.
Kind of just going off what you were saying. So I'm originally from here, from Colombia. I grew up in Texas, and now I'm back here doing medicine. And what you pointed out about AC and air conditioning. So I don't have any air conditioning here. It's been pretty cold recently this week. What suggestions, or like, what do you guys think we could do to mitigate the risks of extreme heat in places that don't have as much access as America?
Yeah, that's a huge question and a great question. I think it's funny because even though the United States does have all these resources, they're not necessarily always equitably distributed. And so there's definitely parts that are experiencing really similar conditions that you all might have there. And so a lot of it comes down to policy and appropriate city planning and appropriate allocation of resources and understanding exactly where the need is and what kind of need you have. In the US, we're very state-based, and then each state kind of is doing something different. Each state will prioritize things differently. So how we do it is really up to where the need is and how quickly can we distribute it to the areas that need it the most. But we won't know how to do that unless we understand exactly what it is that we need, who needs it, and when. And so that's why this kind of research is absolutely critical to really understand and be able to get the resources to where they need them.
Thank you.
Yeah.
There's also like kind of simple low-tech interventions that we can recommend for people who don't, like across the Pacific Northwest, that was one of our big issues, was that we're not used to this type of extreme heat. And so when it comes, nobody has air conditioning. So simple interventions like making sure that blinds are closed. You can create like cooler spaces in your house. You can not cook inside, or not use the oven. You can use fans strategically to cool, to make sure that if you are inside, the inside is actually cooler than the outside. Sometimes the opposite is true, and people think that they're sheltering inside, but inside's actually warmer than it is outside. Yeah, cool baths. So there are a lot of kind of lower tech things that we can help educate people on, to kind of bridge the gap until we can do better in rolling out higher tech solutions to get cooling centers and get better access to these things for people.
One of the things that I always struggle with too, and I'm curious if anyone else has this thought, is that, the very technologies that we need to keep people cool are contributing to the problem of climate change, right? So it's just kind of like, we can talk all we want about making sure everybody has AC and maybe even getting insurance companies to reimburse AC units so that every apartment, everywhere in every state or country has a AC unit. But if those technologies are contributing to the problem, is that really necessarily a solution? So I personally struggle with that. I have no good answer to that at all. I'm just curious if anyone else has had any thoughts on that too.
I feel like that has to do a lot with like where you get the power to like generate the electricity to run those types of like technologies. And I think that is like so beyond the scope of like healthcare for some reason. Just like the same thing, like hospitals are contributing like massive amounts of waste to like, the general just waste creation of the world. But it's like, we need those because we need to help people. So I think it has to do with like, I don't know, engineering, making more sustainable like devices, but also like how are we powering the devices? And that's like, I feel like we could advocate for these changes, but like, it's like, we can't actually do anything about it almost. So that sucks. So I feel you.
Yeah, I've had a very similar like internal struggle about that. But like I had one specific patient who I did not ask any of the right questions. Like I did not ask anything about heat or her living conditions. But she advocated for herself. It was like in the middle of winter, but she said like, I have asthma, I'm homebound. She had a lot of medical, like chronic medical conditions, and she had us write a letter. She was living in public housing, so we were able to write a letter to like get her AC in her public housing. And I'm not sure if it worked, but we at least could do that for her. And I struggled with like the fact that we were kind of creating more waste by doing that, but also she was the patient in front of us who was suffering for things that were like totally out of her control that are kind of like on this bigger scale. So yeah, in my free time, I'm trying to like help with those bigger problems, but trying to like give myself some grace for trying to help the individual as well with the cooling that they need.
I feel like during school, they don't really talk about how to like triage patients properly with like social services. I haven't gone on rotation yet, so I don't know if you learn that more once you actually get on rotations. But like we don't talk about what resources are really available to patients, for example, that can't afford like AC or, stuff like that. So I don't know, maybe you learn on rotations. So
I think I guess my response to that would be look to your social work colleagues, I mean, that's kind of the value of an interprofessional team is there's no way that in your pharmacy school or medical school or whatever, you can learn about all of these things. But if you kind of at least learn who on your team or who around you would have the information and would know that and be able to connect patients, I think that's sometimes the best you can do to prepare yourself as you're headed out on rotations and beyond.
Yeah,
I just have
oh, go ahead.
Sorry.
No, go ahead.
I was just gonna say I had another question, but you can answer that before if you like.
No, go ahead.
Okay. I remember like a lecture I went to a while ago. It sounded like there was some data that said that like for example, the Pacific Northwest or like the Northeast of the US where we're not used to these kind of temperatures, that it's like more dangerous for us and there are more deaths from like heat stress because of that, like, I guess fluctuation of like, we're not used to it and then it happens. Do you know any data about that or is that true or is that like not really what's happening?
You mean for the Pacific Northwest specifically, that heat wave?
No, I mean for populations in general that are not used to like warmer temperatures that are now getting heat waves.
I see. Yeah, I personally, I'm not aware of anything that's answering that question specifically. I know that for the heat wave in the Pacific Northwest, there was research that was done. They call them like attribution analyses and things like that, where they try to look at these questions. And I can get you, I have to look into exactly where the group was that was doing it. But it's a little bit tough to figure out how to baseline these things because they do happen infrequently as of right now. And so it's hard to model exactly how prepared versus how unprepared versus how prepared a place could have been to really figure out those kinds of like the nitty-gritty of those kinds of questions. But I think as these events start happening more and more, they're going to be able to baseline and model how they're actually affecting these communities and what the preparatory steps should have been or need to be taken. But yeah, great question, Emily. Maybe you'll be the one to do it.
Emily, I can share, I'll find it and put it in the chat. There's like a very simplified map that shows like peak hospitalizations based off of the modeling that Emily's talking about, like what you're talking about certain populations not being acclimated to the higher heat. So I will find the map. It's in Climate Central, and it's, don't take it as verbatim, but it does visualize, I think, what you're talking about.
I was also going to mention that based on what we were chatting about earlier about relying on your team and your team members to sort of have the information that you don't necessarily have and how critical that really is. And like, all of medicine a lot of the times is very siloed. And so a lot of this kind of patient interventions tend to get siloed as well. So you might not be aware of resources that are available to patients, but your social worker definitely will be, and definitely feel free to lean on them. But to Raluca's point in the chat, does this represent actually a failing of the education system? Like, we should really all be able to have a understanding and a connection, be able to make that connection between the effects of climate change on health, since we're all working in the health field. And so that's exactly what a lot of these courses are for, is to kind of fill that gap in the interim while there is this push, at least here in the United States that I'm aware of, to integrate climate and health education into nursing schools, into medical schools, into social work programs and things like that, so that we don't have these types of problems and these types of gaps. Because I would say that yes, to the points that were made earlier about how maybe the energy usage at a hospital, for example, is out of our scope, out of our expertise. That's true in the sense that you and I are probably not going to design the next solar panel for a hospital. But what we can do as health professionals, and we can basically use our super trusted voices, and we're really powerful voice in the healthcare systems, that when we are worried about something, people typically listen. So if we're worried about our hospital's energy use and we're worried about our hospital's waste, and we speak up about it to our administrators, and we can speak to it in a not even an expert level, not like knowledge base, but just enough to be able to highlight the connections like we're doing today between illnesses and climate change. It's a huge force in a lot of these hospitals. And I can speak from personal experience to that as well, that they always want to hear from the clinical team on what's actually important for the delivery of healthcare. I see Harsha has her hand up too here.
And just to interject real quick, and then I'll pass it over to you, Harsha, just since we have 5 minutes left, and we will try and finish up on time. I did put a link in the chat to a feedback form, and I'll put it in there again, and we'd love if you could fill that out. And then just as we're wrapping up too, I'm going to throw in our last slide, and maybe we can talk about some resources that are available to share with patients. So, and thank you all. This has been a really great conversation. So.
Hi, yeah, thank you so much for the presentation. I have a perhaps slightly controversial question, but perhaps not. I'm in Ireland at the moment, and healthcare here is obviously, free at the point of access, which is really lovely for people that are marginalized, perhaps, but obviously it's not perfect. But my question was, when patients, like, there's so many factors here that we cannot change immediately. There's so many things that we have no control over. Is there anything from a immediate physician point of view that we can, prescribe, or any treatments or management plans or anything like that that will help, aside from the suggestions that, lower individual risk and modify behavior to lower individual risk? Obviously, managing something that is so societal with another prescription is not ideal at all, but it would help immediately, if that makes sense.
So you mean in terms of, so you mean not on an individual patient level, or in what kind of schema are you talking about? Just so I can better understand the question.
I imagine in an individual patient level, because we have, all these medications that increase your risk of heat intolerance and lower your ability to self-regulate temperature and that kind of thing.
Right.
Is there anything that counters this? It's a weird question, I know, I'm sorry.
I think having the understanding of the sensitivities for these patients is important. So I think that knowing what medications the patients are on, knowing how you can change them, what you can offer on how to change them if, let's say, a heat wave is imminent, is one of the things that you can do immediately for your patients. Providing them, just letting them know that they're in a high risk group. A lot of patients don't even know that, and a lot of healthcare professionals don't even know which groups are actually most vulnerable. So pregnant patients, for example, is another group that they might not even be aware of their risks. And neonates, children are another group that have issues with thermoregulation. So these are all kind of sensitive groups that should know about their risks, and that their provider should be the one to really tell them about it and be in the know about it. I think the more patients you can touch that way, the better off that a lot of the kind of impact that you can make most imminently, while at the same time trying to be a voice at your hospital, wherever it is that you're working, trying to be a climate champion wherever it is, to just kind of be the example of, hey, this is a sweeping problem that we have globally and we need to do something about it, and just kind of being the champion for that. I'm not sure if that answers your question or not, but that's kind of how I practice. And actually some of these resources are ones that I personally use regularly with my patients. The OSHA heat safety tool is an app that you can share with your patients, where they can just put in their zip code and it'll show exactly what their heat index is for the day for their region, and kind of offer protections based on that. And the EPA Air Now app is another one that will tell them about their air quality in their actual region based on zip code. And it'll again give examples of sensitive groups, and then how they'll say something like, if you're in this sensitive group, you shouldn't be outside during this time. Those are some examples of things that I use on a daily basis with patients. I'm sorry if that doesn't answer your question.
No,
I'm
I
sorry.
I do follow. No, you're good. Thank you.
Well, excellent. That was really awesome. Thank you all for participating. I guess that's it for us for today. Yeah, thank you.
Thanks, everyone. And I will put my email in the chat if anyone wants to get in touch with me or has any questions. But thank you so much for sharing this with all of us. And thank you, Haley. Thank you, Aaron, for having us too. I learned a lot.
Thanks, guys.
Thank you all.
Thank you.
Thank you.